do that. We have one more presenter, Lois Gates. She works extensively in the realm of addiction, medicine and intervention. She works very closely with one of the doctors in our area that does opiate detox. And I want to welcome her here to talk about psychosocial interventions.
Thank you. One thing that I would like to focus on this evening is the idea of an assessment. So oftentimes when a person or a family walks into a clinic that where they're attempting to get some type of treatment, they go through what's called a biopsychosocial spiritual assessment. And oftentimes a person will just blow through that verbiage and just say they're going to do an assessment without any clear understanding of what that is, what compromises that as far as the assessment goes. And so I wanted to just kind of go through this with you in a basic way to define what this is about, and then kind of pull off of what the other presenters have talked about and ways this assessment kind of brings everything together and at the same time refers out. So it becomes kind of this point of resource based on what we think of as person-centered care. So the biology, the bio of the biopsychosocial spiritual is the biology of what we're gaining from the person who is sitting for the assessment. And as most of you probably know much more than I do, but biology basically is the science of life. It's what that person has experienced, and it could be at a cellular structure, it could be a genetic makeup, it could be medical conditions or medical complications, whether they think or are experiencing those complications or conditions, or whether it's actually been a diagnosed situation or medical condition. And then the idea is through that biology, one thing we like to determine is whether the conditions that they're bringing forth, are they part of the substance use, part of their opiate use or drug of choice use, or is it autonomous of their addiction? Is the fibromyalgia that the person has been diagnosed with, is that standing in and of itself, or is the fibromyalgia a manifestation of the years of opiate use? So the biology of that assessment brings us with information to know that person a lot better. And a lot of times, at least at the clinic where I work, is we gain that through medical history, through medical records. And one of the things, Dr. Rice, who is the medical director that I work with, that's one of the kind of conditions that we have, is that we really want that past medical history, because it's such a good precursor for where that person is on their biology makeup. Which one makes this? Ah, good, I did it. And then of the biopsychosocial spiritual assessment, the psychology of the assessment helps us really gain information on not just the emotions of the person and the thought processes of the person, but the way they kind of put that together and how their emotions and their thoughts really create this place where they're at. It takes a lot of courage and bravery for someone to walk into a clinic and even ask for help or get an assessment. And so the psychology of that piece kind of gives us insight to where that person is. Along with that same vein, I guess, would be, what are those diagnoses? Do they have mental health, prior mental health assessments or diagnosis done? Do they have any cognitive limitations? Where are they at with their own thinking process about either their dependence issue or their pain issue or their lifestyle issue? The social part of the assessment is just the whole sociology of us as human beings. And sociology is, in a basic way, just the study of relationship. We are social beings. Even people that isolate are still social beings in a certain way. And so the assessment tends to give us insight on ways that the relationships that the person holds, how those relationships actually influence that person's behavior, influence their self-perception, influence the way that they carry worth or dignity of themselves, or how they see their perception of fitting in the world. And we can gain that in a lot of ways. Culture is a big piece. And respectful of culture at a person-centered care carries a lot of weight, because if we're meeting a person where that person is at, and kind of one of those foundations or one of those levels is culturally influenced, we know that we can gain a better therapeutic relationship, and in that way gain a better understanding of what that person is bringing forward, and therefore how we can help them better. Ethnicity is always a mainstay, regardless of the location. Even when we're living in a community where it's predominantly Caucasian or white, people come from so many different ethnic backgrounds. We're really more becoming a global nation in a way. And I think ethnicity is something that a lot of people don't even recognize as being an influence in their daily life or their daily activity or their own self-perception. And location, being in a large geographic county with not a huge populace, like a frontier kind of area, location has its own social influences, and some people see that as a strength. They wouldn't live anywhere else, and some people are really impacted in a negative way by being in a certain geographical location. I just like these two pictures. I like the one picture because it just kind of shows, kind of like the room tonight, It's people coming in from all over. Nobody really knew who was going to show up tonight, and yet we all come together for a kind of the same want for the same information, want for a little bit more understanding, and I just really love that picture. Then the other picture is just some people's perception on their view of how they're treated or how the world is treating them. It's so paradoxical. Everybody has this perception based on their own experiences and their own interpretation of the world of which they live. I really like this picture too. So spirituality to me is the fourth leg of if you're on a three-legged stool, it's not quite so stable as if you have four legs, right? So spirituality oftentimes isn't as focused on in assessments, and oftentimes when people are ill, chronically ill in whatever way, they've lost hope, and they've lost their own sense of worthiness, and they've lost their own sense of how they fit in space and time. And so somehow reconnecting them or letting them know that they're part of a bigger whole, or getting an idea of, once again, their perception of being part of a bigger whole, spirituality carries such a great weight. It really is what connects people. And within that therapeutic relationship, once again, spirituality is just a really good connection of compassion and care and dignity and respect, and those things that carry us as human beings, no matter where we're at or what we've really experienced. The assessment that's done really kind of pulls kindly information from that individual to gain a little bit better insight on that person's value of their own inner strength and wisdom, which, quite frankly, that is the key for treatment. It's that person's perception of their own inner strength and wisdom that will be the motivating factor for them to move along in recovery. It's a leap of faith, and it's a huge step of courage to walk into treatment, and so helping them connect to that type of inner strength is the one thread that will continue to pull them along. I don't really have any case examples tonight, but I wanted to talk to you a little bit about why the assessment is important. The assessment is really important by gaining all that information together because, well, for two reasons. One reason is that it provides the individual who comes in to do the assessment with a period of time in which they can hear themselves talk about or try to figure out verbally what has brought them to seek help. And that's very powerful. It helps a little bit of clarity. It helps somebody figure out what they're saying and get a little bit of feedback of what they are being heard as saying. So that's one big piece. And the second big piece of the assessment is taking all that information, the biological information, the psychological information, the sociological information, and the spiritual information with their history, their family history, their makeup, their strengths, needs, abilities, right, preferences, how they see where they want to go with this. And it kind of puts it together in a nice little bundle and allows that person to then pick and choose what's their next best step and where would they like to go with that and what's available to them. So besides therapeutically within a treatment program, whether it's cognitive behavioral therapy or acceptance commitment therapy or dialectical behavioral therapy or, breathing, that sort of thing, trauma-informed care, regardless of those kind of therapies, it's also providing them resources of other things that might help. So what David talks about, all that myriad of things that kind of fall under the umbrella of physical therapy and holistic care, right? That there's actually those resources available. Or what Tina discussed as far as pharmacological medications or things available for therapy in that way, and what can be done and at that clinic level. If there's a medical director on board, what can be done right then and there for those needs. And then like Dr. Grable was talking about having a psychiatrist or an MD or somebody right there to give more like a psych eval and provide them with more detailed medical information, or coordinate care with a primary physician so they have access to that kind of communication. That's basically what an assessment is what its direction is motivated to kind of collect. And so I don't know, I think that's about all I have to say as far as an assessment goes. I think one of the things that, I really like that picture too. One of the things about the clinic where I work is we see such a diversity of people with all types of chronic pain issues. Mostly it's substance use dependence. So mostly the person has been, whether prescribed or not, taking an opioid of some form, pills, Dilaudid, heroin, whatever, for such a length of time that they're no longer able to stop on their own. They now meet criteria that they need more to get in a desired effect or somehow become problematic. And so mostly that's what we see in the clinic. And whether that person is kind of, a homeless person who isn't employed, or whether they're chronic pain and struggling, but on whatever that spectrum is. Those are kind of the diversity of people that we see almost every day. And the assessment takes every one of those people on their own individual way and helps them find a pathway toward this place where they want to go, where they're motivated to try to feel better and improve their quality of life. Well, thank you so much.
Were there any questions that anybody wanted to ask of any of the practitioners that are here? We ran out of time, maybe, and I wanted to give a minute. I know that our pain doc is gone. I was never told to speak up when I was a kid, or now. one of the things that was stated by one of the clients that I have in one of the chronic pain groups that I do is she was noticing the other day that when she drinks water, enough water, she is in less pain. When she does not drink enough, she's in more pain, which makes sense considering the amount of fluid in our bodies. The last thing I want to say that has floored me with regard to chronic pain groups is, and I'll just, this has happened just in a couple of different ways, and it continues to unfold. What the first group that I ran, there was a woman who said, you know, one of the ways that I deal with chronic pain is I make bears, and I make bears for our local shelter. And if any of you have ever sewed, do you know how much it hurts to sit at a sewing machine? I was floored that she does this, and this helps her with her pain because it is her passion. What I found is that within about 2-3 weeks, people in the group started to bring her material. And they had found it in garage sales and different places, and they started to bring her material so that she could make more bears. And at the end of the second session that she attended 2 in a row, she brought me a bear. That was really sweet, and gave that to me. I was amazed that there was another interaction I walked into one day, and it was an 80-plus-year-old woman with chronic pain that was talking with a relatively young, I would say early 40s, man who is coming out of severe opioid addiction. And they had both lost their spouses, and he makes jewelry out of stone, and she was cleaning out her polished stone from home and bringing him week after week this polished stone to make jewelry with. And they have this connection to this day that came out of that. And it was a little bit like the church lady meets the street addict, and they find in the sharing with each other a sense of community that they did not previously have. And so that's been a really very cool thing that has come out of that, and they've become a support group for each other. So, yeah.
The chronic pain class that you teach, is it the chronic pain curriculum from Stanford?
It's a collection of all kinds of stuff, including one thing that has not been mentioned tonight is we also work with graded motor imagery. So if you have not heard of graded motor imagery, you might also want to look up just that, graded motor imagery online. It's amazing stuff. Lorimer Mosley is a chronic pain specialist out of Australia. And he works with a guy out of Denmark and another guy, David Butler, out of the UK. And these guys are the guys that started cracking the code with mirror therapy on phantom pain. And what they've done is discovered generalization. So what they've got is incredible help online, phone apps, using left-right recognition, believe it or not, to help with chronic pain. It's amazing stuff. So I've basically created a curriculum with 16 topics and then moved from there into some neuroplasticity stuff, graded motor imagery, and hypnotherapy. And so we meet every week and do that together.